Compose myself. There we go. Classic that, Ben.
That's what it says on my screen.
Okay, fabulous.
I can still only see 2 people.
Don't you worry. More than 2 people are coming, trust me.
Oh, there we go. 3. Here we come.
There we go. You're reassured now, aren't you? You are absolutely reassured. Okay, so good evening, ladies and gentlemen, and welcome to tonight's CPDme webinar. Excuse me, I just have to compose myself. Ben just had a panic moment before we went live and said, Andrew, there's only 2 people on this webinar. And I went, there is, Ben, just me and you until live. So there we are. I'm glad Ben's assured now that we can actually, I can see 72 people, 78 people, 81 people. Fabulous. There we go, Ben. Totally reassured by that number. So good evening. Welcome to tonight's Andrew here from CPDme, and I'll shortly be handing you over to Ben. If you haven't done so already, pop in the chat where you're dialing in from tonight, maybe what interests you around ECGs, what you do for a living, and that would be fabulous. Webinar facts. If you've never been on a webinar before, we can't see you and we can't hear you. So if you're sat there in your dressing gown or you're sat there in your nightie or your pajamas, don't worry, we can't see you. And equally, we can't hear you, so you don't need to fumble around for the mute button. If you have any questions for Ben, please do pop them into the question and answer box. Ben might pose some questions out tonight, at which point you can respond back to him in the chat. And then we'll do all Q&As at the very end. If you are a member of CPDme, you will, of course, as always, get a CPD certificate that will come tomorrow morning about 10 o'clock. It will drop automatically into your CPD portfolio. And if you have our mobile app, it will literally tell you when that certificate's arrived so that you can go in and reflect around tonight's learning experience. And then that will complete the learning circle, that magical learning circle that we often try to avoid in that CPD portfolio building journey, of course. So a copy of the recording will be available on YouTube for about a week, and then it will literally drop into the CPDme members area. So CPDme members will be able to have access to this recording and also catch up with their CPD certificates automatically. And of course, that will also drop into your portfolio. If you are on Twitter or Instagram, please do follow us at CPDme. And if you are having a relaxing evening tonight, maybe snap yourself, send it to us on social media and use hashtag CPD Made Simple. And so I'll make sure I give you a like and a little thumbs up throughout the presentation. If you are like me and struggled with your CPD recording, as I said, then CPDme might be the tool for you. We have an absolute amazing mobile app that allows you to capture and record your CPD on the fly. Takes an average about 2 minutes to create a CPD entry. That's including capturing certificates and evidence. So please do download the mobile app. And if you are a premium member, you have amazingly about 25 premium features, including access to over 300 recorded CPD webinars and 80 live CPD webinars per year, all with automated evidence and certificates. So please do join. $1.99 for a month. Can't even get a cup of coffee for that, but I will guarantee you, money back guarantee, in fact, that if you don't like it and you can't get used to it within that month, we'll give you your £1.99 back and we'll shake hands and we'll leave it there. So please do consider joining us as a premium member if you're not already a member on board. Please do follow us on YouTube. When we go live on YouTube, sometimes these channels get pretty full. And if we do, because we're oversubscribed, you can always catch up to us on YouTube. And of course, if you can't get into the webinar room for whatever reason, because technology says so, you can always jump on YouTube. So if you do subscribe, when we go live on a webinar, it will notify you. So if you've just got in the bath, for example, and you forgot we've got a webinar on, if you subscribe to us on YouTube, YouTube will notify you that we have gone live in a webinar, and you can splish splash in the bath while you're watching Ben splash it, no pun intended, doing his webinars. That was good, that wasn't it? I'm probably wasted in emergency medicine. I probably should go into comedy. Definitely. Speaking of comedy, if you leave us some genuine feedback tonight, and I'm going to show you that you're going to be very impressed with this. We did have a very kind member send us a bingo machine this week to do our raffles with, because as you know, Ben, we do our raffle, we pull a little ticket out of the box and we pull somebody's name off. But look at this amazing piece of technology.
Ooh.
We have the name wheel spinner. So if you give us some feedback tonight, I will put your name on the golden wheel, and at the end of tonight's presentation, I will pick 2 winners who will get a £25 digital Amazon voucher. So I'm going to leave the links in the chat just after Ben starts. So please, at some point tonight, leave us a review on Trustpilot, the App Stores, or Google. And of course, we'll reveal the winner. If you're a CPD champion at work, then please do consider downloading our poster and sharing it within your work colleagues, and that will give them access to all of our free webinars. And of course, if they then become a member, they'll get automatic certificates and everything that goes with it. So if you are a CPD champion, please do consider downloading our poster. And of course, if you haven't already got our mobile app, then it's completely free to download. Please do download it, because it also makes registering for these webinars super simple with a simple click. So you can either scan that QR code or just search the App Store for CPDMe, and you'll be able to download our latest app. I will tell you, though, that our app icon is changing very shortly. It's looking quite swish, and we're just waiting for our next app update, and that will happen. Speaking of happening, where has the T-Wave goodbye gone? So, Ben, over to you.
Cheers, mate.
Or should I say flight commander, Ben, because you look like you just come off an X-wing.
I wish. So I need to do something with this, don't I? Yes. Desktop. That one. Share. Okay, can everyone see that okay? Can you see that okay?
Perfect.
Perfect. Good. Once again, thank you for CPDMe for inviting me back. As we all know, this is part 4 of a 6-part series. We're going to get onto that in a moment. Where's my little cursor? There it is. There it is. So the plan. For people who've been following the series, we've already done the principles. I did that 3 months ago. My mum absolutely loved it. She gave a 5-star rating, which I was really chuffed about. The second one was about AV, left, right bundle, Wolf Parkinson White. My mum didn't think it was quite as good, so he only got a 4.9-star rating. And then last month we did the unhappy QRS, and I bumped into one of my colleagues who only works the next ambulance station over from me, and he said it's the best one I've done. 5 should be the star rating, but I thought I'd give it a 5.1. Today we're going to look at the T-Wave, just the T-Wave, nothing else, just the T-Wave, and we're just going to be looking at a few finer points and things that we should necessarily be looking out for. The next one, which is next month, we're going to be looking at the ones that doesn't quite fit into any of the ones above. So atrial fibrillation, SVT, atrial flutter. We can look about rate related. Why when things go fast, they change. Why things go slow, they change. We're going to spend not very long, a brief period on pacemakers. Last month, someone asked me about Takotsubo, and Takotsubo is a bit of a natural hormone imbalance, but I've kind of coined it under this one. We're going to look at that under chemical imbalance, and I'm going to include Takotsubo under that one. And then number 6 is we're kind of looking at a Saturday morning, about 4 to 5 hours. And for me, it's the tips and tricks to never miss an unwell ECG. So even the fact that you may not understand exactly what you're looking at, if you follow these tips and tricks, I guarantee you will never miss an unwell ECG. For anyone who's done my teaching before, when we talk about language, I may use a terminology, for example, myocardial infarction, and I'll follow that up with the more layman's terms of heart attack. Similar thing if there's a word, for example, ischemia, which comes up quite a lot in this one, I may follow up with lack of oxygen and nutrients, and then I may just kind of flip between the two depending on where we are. But hopefully, I've said at the beginning, you should understand it all the way through. I don't know where you are in your journey, so I want to make sure that everyone understands. And I already noticed there's some cardiologists in this, also some student paras. Everyone will be able to understand everything I say. Specificity and sensitivity. This is really, really important on this one. I'm aware that everything that I kind of teach, this is not 100% accurate. If you understand what specificity and sensitivity means, go back to watch the principles and I explain it in more detail. But the reason why I say everything's not 100%, I'm not a cardiologist, and I know by looks of the chat there are some cardiologists and some cardiology nurses and probably some people who love this type of stuff. But we just need to work safely. We need to know that we're going to do the right things for our patients. And I would rather a member of ambulance staff arrive in an A&E department, show what perceived to be a wonky ECG, and the doctor go, that's fine, as opposed to leaving someone at home with an ECG they're a bit unsure about. Let's make sure we work safe, because that's the best for our patients. The plan for tonight, We're going to look at why up when it should be down, normal but not normal, action potential, anatomy and physiology, the usual suspects, and I'm going to do a bit of a summary. Over the previous weeks, I've been asked a couple of questions, which I didn't answer on those because I needed to go back and do a little bit more reading, and I've got the answers. There's one question on the back of this one. And as we know, if you have any questions during the presentation, stick them in the chat, and we'll try and answer them as we go through. So let's kind of go back. Let's do a little bit of recapping of the electrical process through the heart. Make sure I've got my cursor perfect. So we've got to remember that, as you see, we've got a negative and a positive. And the initial phase of a heart beating is positive electricity. So we have this positive moving downwards, giving us our P wave. Then we have a brief pause. Then we have this little Q wave. Lots of funny things can happen in a Q wave. Then we have our RS. So all of this is positive electricity. This is given our PQRS. Then it pauses for a period. And then we get our T wave. So this is negative electricity moving away from a positive. Now, why have I gone through that? Why is that relevant? It's actually pretty relevant. So this picture here, if this was positive electricity moving towards a ECG dot, it will give us this nice positive electrode. And when it gets to the top, it means electricity is stopped or it's changed direction and this ECG dot can't see it. So it's got to go back to the baseline. And similarly, if it's positive electricity moving away from an ECG dot, it's going to give us the opposite. It's going to give us this negative deflection up and down. Oh, where's my little board? There it is. So let's just kind of recap that just so we understand. So this is my ECG dot. So far, if this is all positive electricity, so just as that picture said, positive away and so forth. So this top one, up, down, this one here is going to give us down and up. So now if we have negative electricity and it's moving towards the ECG dot, we're going to give a negative. And it's moving away from the ECG dot, it's going to give us a positive. Okay, so it's just everything is in reverse. That's all it is when we talk about negative and positive regarding the deflections. Ooh, why is it not flicking? There we go. So normal but not normal. So this is the bit we need to kind of understand. We've already started looking. Oh, that's why it's not. We all need to understand. So if we have our picture of a heart, let's do it in black. So from previous pictures, everyone should understand why I've drawn this. And then we have our general electricity for our P wave, and then we have our Q going this way. So we've now got our, and we've got it this way. So at the moment, it has all only moved in one direction. But now we've got our negative electricity, which wants to move in this direction. So if our ECG dot is here, as per the previous slide, it's going to give us this negative, this positive deflection. Even though it's negative electricity, it's moving away from the ECG dots. So what have I said on the previous slide? Normal, but not normal. Ooh. And that's because in some views, let me just get rid of some of this. Ooh. There we go. In some views, we may very well see, so we have a picture of the heart. In some views, we may still see this negative T wave. But why? Well, let's have a little think about it. So I've got this little picture here of the vectors. So as you see my little cursor just by the collarbone as I put it down, electricity is generally moving in this direction. So almost like the best way I always describe it from students is going from the right hip down, sorry, the right shoulder down to the left hip. That's the direction. But when we have our T wave, it's moving in almost the opposite. So it's moving in this direction. So some views almost see the opposite. The negative electricity is moving towards them, which we know is going to go down. Oh, have I got the wrong slides come up? So if we were just to look at this one, we've got V1, lead 3, and AVR could very well potentially have a negative T wave. So also let's continue with a little bit of normal. What is normal? Now I've got this little picture over here to the right hand side. We've got a QRS. We're not too worried about the P at this point. So QT interval. So the beginning of the Q wave to the end of the T. That's the bit that we're measuring because we want it to be a reasonable distance. And I've put here up to 440 milliseconds for men, 460 milliseconds for women. If it's over 500 milliseconds, it's deemed as dangerous. They could easily flip into a rhythm. The one that we're kind of considering is Toussaint de Poix. A lot of people say it's kind of VF. If they're Toussaint de Poix, VF doesn't really make a difference. The treatment's pretty much going to be the same. If they're conscious, which they may be briefly, once they're unconscious, chest compressions to defibrillation. And then we talk about height. Limb leads, 5 small squares, and chest leads, 10 small squares. And for any of these two regarding height, always take the biggest reading, wherever it is on the screen. Okay, so if you're looking at the chest leads and it's V2 or V3, we're going to look at that one. If you start reading textbooks, they say it must be in particular leads. For me, I want to work safely. I look from 1 to 6 and just take the biggest. Sometimes the height of the QRS is relevant. Sorry, the T wave is relevant to the height of the QRS. If you have someone who has large amounts of chest adipose tissue, you may end up with a smaller QRS, and then actually the T wave looks big in proportion to the QRS. So you've always got to make that as a consideration. Calculating QT intervals could be quite difficult, and I use LifePack 15 when I'm working on the ambulance. This is just an example that I've taken, and as you can see here, it is QT, QTC. It's already given me to what it is, 0532. Now this is a left bundle branch block MI, or a left bundle block ECG at least, and it's giving me my QT. So a lot of machines will actually calculate it for us, and this is probably one of the few times where I actually look at what the QT interval is. A lot of the time I look at it by squares and so forth, as I find that easier. So normal, but not normal. We've already kind of alluded to it. We may get a negative T wave in V1, lead 3, and AVR, but AVR should always be negative anyway, so we're not too worried about that one. Some textbooks would say having a negative in lead 3 could mean something. I'd say if it's isolated and it's on its own with no other T wave changes across a 12 lead, I'm not worried personally. And this kind of just alludes back to the lead 3, V1, AVR. Think about what direction electricity is going in. It's negative, it's moving almost towards them, so we may get this positive T wave. Throughout the previous ones, we haven't even talked about this action potential. It's not necessarily the action potential I want to talk about, it's these bits here, the chemical elements that we need in our heart. So we know at rest it sits about 90 millivolts, and then when we receive the action potential, it goes above. Then we have a brief period of pause that allows the muscle to contract, and then obviously it relaxes. But all of that is relevant to these 3 elements, and we're going to talk about that in a couple more slides, but I just thought we need to get it in there. Anatomy and physiology. Okay, this is where everyone gets to see my drawings. So we've kind of got a picture of the heart, which I've drawn many a times, and then I'd normally draw the muscle of the heart, which is something like this. But actually what we'll do, we just want to look at a small cross section of this. So I'm going to draw it like this, where on the inside we have our nerves, and then on the outside we have our blood vessels. Yeah, nice and simple. So what happens when the heart contracts? We get this electricity moving in this direction, which gives us our nice. Now you'd think if this was in a Mexican wave type thing, because this end here contracts first or starts, the electrical impulses first. This would be the bit that repolarizes first, but it doesn't quite work like that. And the reason being is because of these blood vessels. These blood vessels are not just sat here on the end. They're kind of going into the heart muscle themselves. And the best way I describe this is like the Uber highway. It's going to be the fastest way for those chemical elements to switch back the other way. And because of that, we then have our repolarization goes this way. And that's why we get this one here. Now, let's just say, hypothetically, that blood vessel is blocked. Doesn't sound good already, doesn't it? Now, we're still going to get it going like this as before. But this blood vessel is not there. So all these little blood vessels are also not here because they're blocked. Now, it wants to repolarize. And this end here is thinking, well, if it's not coming from another way, I'm going to start repolarizing. So it's going to go that way. So what we see, we get our normal, and then also we get our negative. Well, that's not good, is it? We talked about this kind of blood clot kind of here, and that's not good. That's not good at all. Just going to get rid of some of these for the next bit. So we already know that's not great. Now, what happens, say, if this part here was not very well, for whatever reason? It was still kind of well enough for this electrical impulse to go down there. So we still get our bit like that. But when it comes to repolarization, it's going to start this side as per normal, but it's going to hit this wall here. So it's going to stop. Well, we've still got this whole section here. So what happens? Well, it starts from this end. So what are we going to see on an ECG? Well, we could see there's our first bit, which is this bit here. But now we've got negative electricity moving towards it. Now this is going to be slower because it doesn't have the blood vessels as this one at the top. So it's going to be slower. So now all of a sudden we've got this up and down through to whatever this is, something in the middle. We're going to talk about it in a little while, but that doesn't look good, does it? Does not look good at all. Right, let's get rid of this. Perfect. Now we kind of alluded, didn't we, to the previous slide. We've got these elements here. And those elements need to be in balance for the heart to work. And I'm no cardiologist. I'm not going to sit here and I'm going to tell you how many elements there are. It doesn't really change how my practice works. But let's just say one of them has more or less. So it now changes the whole balance of what's happening. So what we may see this normal QRS. But as opposed to it balancing normal this way, it's going faster, which is not quite what we want. So what do we see? Well, we have a normal, because it's a quick part of electricity, we've kind of taken part of the hump and we've got this spike bit. And this could be due to a chemical imbalance. I'm not going to write it. I'm not very good with this whiteboard. Due to some kind of chemical imbalance. Or what happens, once again, due to these elements being out? What happens if it's slow? What are we going to see? Well, potentially almost a flat. Well, what could cause this to go slow? Well, maybe we've knocked off the blood vessel. Maybe this bit is out. Maybe this bit is out. And they all don't look good. So I've kind of covered the bad ones. But let's think about some good ones for a moment. Oh, we can still use that one. So we already know this is there. and we know it wants to travel in this direction. So I would say good ones give us a up and a down, up and a down. That's what we're looking for. And when I say up and down, this is kind of perfect, this kind of little dome shape. I'm not too worried. It goes like that. I'm also not too worried if it goes like that. These are all good. I don't really want they are bad. They're camel humps. Very rare to see them, and there's normally a reason we see them. Normally the P wave could be involved, or there's other reasons, but they are bad. They are very, very bad. So we kind of talked about the action potential, and we've talked about the anatomy and physiology. We've got to remember with all of these, it has to be in 2 or more views. So what do we mean by 2 or more views? When you have a 12-lead ECG, we're almost looking at the chest leads, or we're looking at inferior leads. And if you go back to presentation 1, we talk about what views are what views. And if we really want to look at that, we could go back to this one, and it's the group of leads that look at it. So if we had it in V6 and lead 1, that's part of it, or V6 AVL lead 1, they're all looking at a similar part of heart or chest leads and so forth. So when we talk about 2 or more views, so normal, we've just kind of covered normal, we just want this up and down. Tall, and I just wanted to put some examples up really. Tall, 10 small squares, and as you can see on this one is well over 10 small squares, and it's due to a chemical imbalance. And I'm sure there are some people out there saying you can actually tell what's going on by the actual tip of these the T waves. If it's pointed, it means something. If it's round, it can mean something else, and that's great. But as a pre-hospital clinician, and we have to know lots of things about lots of different things, just the fact that we found a tall one is significant. That it is, we're going to question they have some kind of chemical imbalance. Tall with ST segment elevation or depression. So this one here with the depression, you know, I'm a bit of a spod. I know this is the winters, but for you guys, you found depression, which is significant. But now we found this massive T wave as well. So now we know this is not just significant depression. There's actually quite a lot going on this, and this person's specifically exceptionally poorly. And we've got this one here. To me, this almost looks like it could be an incomplete left bundle, but we've got this elevation and we've got this very peaky T wave, especially in this V3 where it's up to or just getting to, or sorry, no, it is over those 10 small squares. So tall, chemical imbalance, heart attack, struggling for oxygen. We kind of talked about these biphasic ones. There were lots of variations of biphasic ones, but overall for us as pre-hospital clinicians, we're just going to think heart attack and ischemic. Ischemic, lack of oxygen, lack of nutrients. Sometimes it could be caused by dead tissue that's in the heart, so we may well see it that way. I wouldn't say it's a usual finding, but you know, from speaking to some of my cardiology friends, it could well be found. Whelan syndrome. There's more than one types of Whelan syndrome, but the presentation, this kind of up and down, is what we're looking for within Whelan's. Inverted T's. Okay, we see inverted T's a lot across many different ECGs. But why? What can be found in? Well, kids, we see them in kids. Could well be normal. You know, if you want to ask me a question, please do. I'm not a speciality in kids in ECGs, and even when I speak to my friend who's a cardiologist, he really struggles with kids ECGs. He would normally refer it to a specialist. Inverted heart attack or ischemic, so that lack of oxygen, lack of nutrients again. Bundle branch block, so we talked about why you may get an inverted T. That was in the not previous one, but the one before that, why you may get an inverted T wave, especially in right bundle, and actually be fine. Enlarged hearts, that's where we have an exceptionally large QRS, and then we may well get an inverted T. Lung blood clot, I think we talked about this in session 1, maybe 2, where you start looking for all those kind of different bits. Yep, it's an inverted T. Yeah, it's in there as part of the diagnostic. And as I say, there's plus others. For me, as a pre-hospital clinician, if I find someone with inverted T wave, it's ischemic till proven otherwise. It has that lack of oxygen, that lack of nutrients. Something needs to be done about it, or I need to make sure I scrutinize it correctly, that it's not part of something else before I leave someone at home or take someone to hospital, or what I decide to do with it. And we kind of already talked about flat. Needs to be in lots of views. So in previous ones I've talked about it needs to be 2 or more views. For flat, it needs to be in lots of views. So if you had it, say for example, it was a flat T waves and it was all in the inferior leads, but yet it was all present in all other leads, I would say that's insignificant. If it was flat across the board or in lots of views, I would then start saying that is significant. Crikey, I've richly rattled through this one. In summary, you know, we kind of don't need to delve too deep into these ones that much. Normal, we just want it to be up and down. Tall, chemical imbalance, or we're querying some kind of heart attack. Biphasic, we've got to question whether it's a heart attack. Inverted, lack of T waves, we've already talked about many different reasons, but for me, if it's got an inverted T, then we need to really consider they've got a lack of oxygen. Flat, ischemics, a lack of oxygen again, or a heart attack. I also wanted to just throw a bit of a special mention to this particular one. So this is called Brugada. I didn't really know where to fit it into all of these presentations because it seems to cover lots of different boundaries. But I think the T wave I think is quite a good one, and the reason being is, so on this, as you can see, there are more than one types of Brugada: type 1, type 2, type 3. And in this type 1, I think it's quite obvious that we may see elevation, but it's only really in one particular view. But what we do have, we almost have this flip T in V1, V2. So it means we may have another type of diagnostic tool that we can use to pick it up. In type 2, once again, we've got this kind of wobbly, potentially inverted, but we've got this kind of up and down. Maybe is that biphasic, or start to get biphasic. In type 3, it is biphasic. And I just thought it's worth us just noting. Brugada can be life-threatening. It can be very intermittent. It could be the reason why people collapse. From what I understand, it's quite common in young people, and especially in sudden death, they could have an underlying Brugada. And whew, I think this is my fastest one yet, of under half an hour questions. But before I actually take questions, I did actually get a previous question from our session before. I can't quite remember. Why does Mobis 2 have a normal PR interval and Mobis type 1 get longer drop? And the answer that we kind of alluded to was that Mobis type 2 is caused by a block within the bundle of His itself, not at the AV node moving to the bundle of His. So that's where it drops the impulse. That part has passed over, and there's a problem a little bit further down the chain. When my cardiologist friend got out the piece of paper and started drawing and writing about it, I was like, that's wonderful. I just need to know that bit. Perfect. And well, half an hour. I've done that in half an hour. As I say, let's open up the board for questions and see what people think.
Fabulous. Thank you, Ben. Indeed, that's pretty quick.
That is pretty quick, isn't
it? So let me have a quick look for you on questions. I can't even find my questions tab. Where's it gone? Where's that hand at the end? We've just got one question from Louise for the time being. So what I'll do perhaps maybe is I will give people the opportunity to put some questions there, because I'm sure there is people sat there with lots of questions. Jason just put a comment in the chat. I've been in Tossards. Was not fun. I can imagine, Jason, I've been to a patient with Tossards and he wasn't fun either.
So Jason, the question to you, did you go unconscious with it, or were you conscious? So I think because we've got plenty of time, let's kind of explain to people what Tossards is. So I'm going to draw the heart slightly differently on this one. I'm going to draw it as more of an upright. And I'm not going to draw the necessary lines. So what we see in Tossards is where the electricity, so Tossards is a French word meaning turning of the points. So what we see electricity traveling in one direction, but it keeps traveling round. So what we see on a rhythm strip, so if you were an ECG doc, and it doesn't really make any difference where you were, and you were here, it doesn't make any difference, so you put it here, and you were directly looking at this part here, while the electricity is moving in front of you, you'd see this nice big one. But as it moved around the side, because it's not directly in its view, and as it moves to a point where you don't see it at all, and then it gets around to this back side, and it may just get a bit bigger, and then as it moves around again, it gets a bit smaller, then it gets to the bit that didn't see, and then we go back to the beginning. So we see this kind of change as it moves round the heart. And I've seen Totards quite a few times over recent years. And if they are conscious, they're not going to be conscious for very long. The reason being is that this is not enough really to generate or to squeeze the heart to create a suitable blood pressure. So their blood pressure nosedives and they go unconscious. So what do? We do CPR, and what's a good primary treatment for them is a defib. So throughout my career, I have shocked one person who was in Toussaint part unconscious, and I've never apologized so much in 2 minutes in my life because I did not have enough time to get sedation on him. But it saved him. I actually found out that he went home a week later. He was a gentleman in his late 60s, early 70s. He did die about 3 years later after that, just because randomly the crew who went to his death also were there on that day as well. But I shocked him. I actually shocked him, I think, 7 times. And I only think the last couple he had enough sedation on. But it's what he needed.
Did he swear at you, Ben?
You know what?
The last time I did swore.
No, he didn't. He was just there. So he was in a sinus rhythm, and then you could see it just flip, the rhythm flipping on the machine, and you could just see him going grey, and I'm just charging it. And just, I'm just apologizing. I'm so sorry. And at the time, my colleague who was with me is sat there, like he had some midazolam in his hand. So we've given him a little bit of midaz. And then he's like, I've now got to give him ketamine. That involves a call to someone. So now we're on the phone, and I've shocked him. He comes back for a couple of minutes. And yeah, and then the same thing happened a few minutes down the line. The thing that actually stopped it is we decided to give him some amiodarone. And that's the bit that stopped him from going back into it. I think my guidelines could change in maybe this year, maybe next year, where I would give a different drug if they're at high risk of this. But I'm not too sure. I'm not smart enough to understand all of that as yet. Fully conscious throughout 35-second burst. Have a great trace.
There we go. Question from Lisa. If someone had an early signs of hyperkalemia, could they only show tall T waves in maybe 2 leads like V3 and V4? Is this possible?
So that's kind of a good question. So when I've done, especially my verification reading, as I do for all my presentations, a lot of them would say you should be looking in V3 and V4 for your tall T waves. And if it goes over 10 small squares, then we have to consider, is it an early sign? No, I think that's quite a complex question, and one that I don't actually think I can answer, because I've been to lots of people who've had a blood test, and they, especially that GP's done a routine blood test, and they said, oh, they've got this and their sodium, potassium, whatever's out, they need to go to hospital, and I've done an ECG and it's actually normal. So I'm not sure if it's necessarily an early sign. I think we need to raise the question of why we're doing this rhythm strip, why we're doing this 12 lead. Are we doing it because they've got chest pain? Are we doing it purely because, they've got a chemical imbalance, let's do it and see what it looks like? But, I'm not 100% sure if it's necessarily an early sign. And it's definitely one that if they did have a tall T wave and asymptomatic, would I question whether they would? I'm not too sure. Next question, is there any way I can get access to previous? You could register online for however much it is, and you get access to all of them and get certificates. I also think they're on YouTube as well, aren't they?
Yeah, some of them are, I think, Ben.
Yeah, I think some.
So if you want the full series, Caleb, you'll have to subscribe online. Then you can access them on the app or the dashboard. And you can. What I did find this week, you can stream them to your big TVs from the app, which is like amazing. You can have Ben in full life, like if you've got a 75-inch HD TV.
So what was the next one? Diabetic patients. I'm not sure. I don't think I've ever really been taught, or everyone has ever really contemplated, especially for DKA, about whether they'd have ECG changes. In my mind, it kind of makes me think they would, but if it's not affecting the potassium, sodium, and so forth, I don't think we would necessarily see any changes. I think we also have to question how quickly the DKA has come on. As I said, I don't think I'd use it as a diagnostic. If someone's got DKA, a 12 lead's the last thing on my mind.
Agree. Sultan, can you explain briefly the delta wave?
Yeah, mate, we've got 20 minutes. Yeah, of course. So, Sultan, on the previous one, on my second one, it was called Wolf Parkinson. Sorry, AV blocks, right bundle branch, left bundle blocks, and the Wolf. We talk about that. But what we're thinking about for delta waves, so this is relevant for Wolf Parkinson White. So what we have, so let me just quickly draw the electrical bits on. So these are kind of
enough.
Sorry?
For those who are old enough, this is a bit like heart attack for adults, isn't it?
Something like that. So what we have actually in the atrium, we actually have some other neurological pathways. Okay, so when we talk about delta waves are relevant for Wolf Parkinson White. So when I do any of my teaching, I say the electricity moves, let's just do it on that one. The electricity moves from here to here, creating our P wave. Well, actually, it whizzes round all of this and then gets to there, and that creates our P wave. So what we see in a delta wave is electricity is firing round, and there is a junction, an accessory pathway which it can go through down into the ventricle. So what happens, it starts depolarizing this part here. So what we see on our ECG, so if you think that normally there's a 3 to 5 small square, but actually this bit is beating it. The ECG dot is here, so electricity is moving directly towards it, but not in a direct angle, so it's slightly sloped. And then we end up with the rest. So what that means is we end up with this delta wave. Now, Wolf Parkinson White, we have this kind of accessory pathway, bundle of Kent, I think it's called. I can't quite remember. Why are we interested about Wolf Parkinson White? So these bits here, these accessory pathways, it can either let it through one way, it can either let it through the other way, or in some Wolf Parkinson White, it will do both. And there is a statistic about which one's which. And it's all about risk of how poorly the patient is. So let's just say they are this. They are the ones who let it in and out. And I've kind of left this gap over here because this just makes it easier for a pictorial. So it goes through there, fires off, whizzes round, skips over there, gets back in, then goes straight up to there, whizzes round, catches on, and keeps going round, and then just keeps going round. Well, what are we going to see? We may be lucky enough that we just see this, or what we may also see is this. And I'll tell you, I know which one I would rather have out of the two. So that's why sometimes we get SVT, and it could be of Wolf Parkinson White origin. Obviously, you just asked one question about a bundle of the delta wave, and I've just thrown in a few extra bits just in case you were confused about any others. I hope that answers your question.
I think it did. It said thank you very much indeed. Question, any pre-hospital treatments for long QT syndrome?
So for long QT syndrome, if you've isolated that it's just long QT syndrome, get them to hospital. At the moment, there isn't. For someone like myself, I do carry a couple of drugs, magnesium being one. There's also talk of getting another one. I think calcium chloride was in discussions. So I may choose, or the thing is for me, it's not choosing. I would have to phone up my on-duty consultant to have that discussion with them about whether I'd give them. For you guys, if you see it, then it's the hospital for them.
Fab. M has asked, In electrolyte imbalance, does this affect all T waves across the entire ECG? Therefore, isolated T wave changes are due to other causes? That's in the Q&A box.
So I think it was Emma. Can't quite remember. I'm going to draw this really long. So for me, this is, let's just think about the anatomy and physiology. The next one down here. If this blood vessel here is okay, then it's going to be fine. If this vessel here is not working, and we still get that, then it could be just isolated to a group of views. Because actually the other group down here are okay. So it could just be like, if you are talking about a global part of, say something's happened, say for example kidney failure is if also the presentation Danger Long Life, feel free to go and watch it, it's magical, and we have a global, then yeah, if we've got an imbalance throughout all of them, then we could really start seeing changes across a broad spectrum of ECG, because it's not the individual, it's not any of this heart muscle that's the problem, it's the whole body is the problem. So yeah, you could very, I think it just helps isolate it. If the body's struggling, potentially global. If it's just part of the heart, then it's going to be isolated to that part of heart. I think it's just big anatomy versus small anatomy. Was that the question? I think that was the question.
Yeah, it's just at the bottom. Wrote it on the Q&A box.
Yeah, perfect. I hope that answers your question. Delta wave, thank you. Is it possible to?
Just got a comment from Jason in the chat.
Yep, go for it.
So great session, Ben. Thank you. When you mentioned negative moving electricity, did you mean essentially a change in state, i.e. heart muscle charge returning to previous charge state? I get the idea of positive or negative ECG trace movements moving towards or away from electrodes from the source, and the monitor flyback always tending towards the neutral or V. Just want to be clear on this meaning of comment.
Yeah, so if this was a heart muscle at rest, electricity is moving through it, we get this contraction. So when it repolarizes and it allows it to relax, we're getting it like that. Does that answer your question? So it's simple fact, as electricity is moving it, this positive action potential is allowing the muscle to squeeze. And why do we need that? Well, crikey, without getting too much into it. Oh, I've drawn that slightly wrong. What we have in the body are these, I've drawn this really wonky, these bits and this kind of ratchet mechanism, and it allows electricity, allows these bits here, which are part of the calcium, to knock off and allow it to squeeze, and this repolarization allows the calcium to go back on for it to relax. So it's just simple fact, as it's moving towards, so this is at rest, this is the squeeze, and this is going back to relax. So this is positive, this is negative. I hope that answers your question. I've gone overkill with Z zones and my zones.
You've taken that heart attack moment to another level, Ben.
Yeah. Is that what someone said?
I am very glad to see that there is people in the chat who do recognise Tony Hart and the old. In fact, what was that little character called? Morph, wasn't it? Who used to draw as well.
Yeah. Good.
I think. Yeah. My older brother used to tell me about it. I can't quite remember, but there we are. Well, I think you've boxed off Q&A, which is absolutely amazing.
There's one more just here. Is it possible to have possible T waves in AVR? AVR should predominantly be negative across all views. If you have a positive T wave in AVR, that is the only one. AVR is the only one that if you have elevation or depression or a change T wave, that is significant. It just needs to be negative. Like if you want me to talk about AVR on the next one, feel free to email in or message me, and I'll see if I can squeeze it in, because we've only got an hour to do it.
Fab. I'll tell you what I'll do while I just close off and show you what the up and coming webinars are. Pop in the chat maybe what you want Ben to cover or anything you'd like him to briefly cover in the next up and coming webinars. And I promise I'll pass that on to Ben and we'll try and get that boxed off. So up and coming webinars, literally there's that many of them now that I'm just not even going to put them in the presentation. So just go across to cpdme.com click onto the webinar tab, and then scroll down because there is literally too many to list, including pre-hospital blood next week, chest injuries. If anybody's watched Professor Richard Stein before, he's amazing. I once watched him crack somebody's chest open. It was just phenomenal. So if you're interested in chest injuries and all things chest, please do join Dr. Richard. Road traffic related injuries on the 6th of April. Then we've got some really good series on musculoskeletal, joints, shoulders, spines coming up soon. We've got Ben back on the April the 19th for the last of the series before his weekend symposium. Shoulder interpretation, head injuries, May the 5th. Lots and lots and lots there, people. Medical imaging of the pelvis. Ever wondered what it looks like when you have a fractured neck of femur or a fractured pelvis? Well, join Graham Kelly, who's a consultant radiologist. I've got another leadership one there by Rusty. Critical care skills in austere environments. That's imagine Ben lifting himself up and landing in the middle of Burnley, maybe, because that'd be quite austere, wouldn't it, compared to down south. Leadership, medical imaging of the spine, quality assurance, understanding standards of practice, lots and lots and lots for you there. In fact, I think we've got a 65 to list. So just jump across to the website and you can see what's coming up. Ben, Saturday Symposium. We talked about this, didn't we, before we started? We're thinking probably going to be May or June.
Yeah,
right,
my rota's just changed. I was waiting for it to change before I confirmed a date, and I only found out this afternoon. So I've got my weekends. I know which weekends I've got off. By means of some of the questions, by means of the next one, we talk about early repolarization and also ECG changes in overdose patients. So I've coined that as chemical imbalance patients. So we're going to look as part of that, those external influences, so drug overdose, and also those internal influences, so Takotsubo type things. And we're just going to look at the difference that those two things can make, and what we should be looking for or potentially looking for in ECG. Out of the next one, probably the biggest bits are the AF, SVT, and the chemical bit.
Fabulous. And Ben's symposium will be listed on here on the CPD events. We have got one that's just booked on fundamentals of QI, and that's booked for November. That'll be coming soon. And then so Ben's, there's so many days away from that, so don't worry about that. But if you did miss the Saturday Symposium, that has just gone live. The recordings are available there now at the bottom of the events page, Spotting a Sick Child. So that was fabulously attended this weekend. So either jump on the webinars page or jump on the CPD events page. All that leaves me to do now is do our little draw, because we've got some amazing people who's left us some feedback. So thank you to all of these fabulous people. Look at this amazing new tool we've got. One of our kind members sent us a bingo machine last week, but we've got this amazing tool. So thank you to Quabina, Lisa, Mary, Harry, Andrew, Claire, Michelle. I think I just need to press the middle button. Let's see who's going to grab one of the £25 vouchers for leaving us some amazing feedback on one of our platforms. Michelle E. Fabulous. So Michelle E, all you need to do is please just email me at andrew.ormerod@cpdme.com or team@cpdme, and we'll get you a £25 Amazon voucher tomorrow. And then let's do number 2. And for voucher number 2, we have, oh, this technology is far sweeter than bingo machine. Harry G, please drop me an email again, and I will make sure we get a £25 digital Amazon voucher to you tomorrow too. So on behalf of myself and the fabulous Ben, have a fabulous evening. Thank you so much for joining us. Your CPD certificates will be tomorrow, 10 o'clock in the morning. As soon as Lauren's had a cup of coffee and a little slice of cake, she'll be on it. So take care, everybody. If you are at home and you're relaxed, kick off your slippers, enjoy the rest of your evening. If you're at work, please stay safe. Make sure you look after yourself and each other. And it's nearly weekend. Stay safe, everybody, and bye-bye. Thanks, Ben.
Cheers, bye.
Take care, everybody. Bye-bye. Bye-bye.
Oh, pardon me.